we have performed robotic Latissimus Dorsi flap reconstruction, and we present feasibility, morbidity, indication, and technique standardization. It's a prospective study with 85 procedures, with more than half of patients with cup size C or more than C, and about half of the patients have a previous radiotherapy, and 32% of patients have neoadjuvant chemotherapy before these procedures. We have used two systems, robotic system Da Vinci, half with SC and half with XI. And we use two arms in a majority of cases, 75% of cases. We have determined 4 periods. The 1 year, 2016, and 2 periods of 6 months next year, and this year about 3 months. Indications for these procedures were 22 local recurrences, 26%, and others primitive breast cancer, about 80% of invasive breast cancer, and 18 DCIS. We have performed 88% of immediate breast reconstruction and 10 delayed reconstruction, without implant in 66% of cases. For mastectomy, we have performed 36 nipple-sparing mastectomy, 39 skin-sparing mastectomy, and 10 standard mastectomy for delayed breast reconstruction. For installation of patients, mastectomy, when performed with concomitant robotic Latissimus Dorsi flap, we used dorsal decubitus, then inside decubitus, and in some cases, about 15% inside only installations, and we have the view of the installation. For incision, for immediate breast reconstruction, we use periareolar incision for skin-sparing mastectomy and only periareolar incision. For nipple-sparing mastectomy, we used axillar incision, and for delayed breast reconstruction, external part of the previous mastectomy scar. We have performed about for half of the patients axillar incision and 26 areolar incision. When we performed nipple-sparing mastectomy, we used a vertical axillar incision 4 to 6 centimeters, and a robotic trocar is put about 6 centimeters under this axillar incision. We use a monotrocar gel point with 2 robotic trocars into gel points, and one for camera with 0 degrees, and 1 trocar for insufflation. And we used 2 instruments, monopolar scissors and bipolar, and camera with a very low pressure. We have the view of the gel point and the view of the light in the dorsal dissection. We study 1, 2, or 3, or 4 procedures. It's important for statistics after, with different procedures: mastectomy, axillary lymph node dissection, Latissimus, Dorsi flap, and breast implant, and contralateral breast surgery. For time of surgery, we have a decrease of time between immediate and delayed breast reconstruction, and increased with a surgical number of procedures and more time for implant in association with Dorsi flap. Time of surgery is lesser for the third and fourth period, but because there is a strong correlation with different criteria and time of surgery, we performed a logistic regression analysis with, in the successive period, lesser time for surgery for this procedure, and we observe the same decreased time of anesthesia for these procedures. Post-operative hospitalization were 4 days in median, with lesser time for third and fourth periods. Morbidity is low, with only one grade 3 complication, 1.2%, and 30 grade 1 dorsal lymphocele. In conclusion, robotic Latissimus dorsi flap was proposed in selected cases in our experience, 21% for immediate breast reconstruction during the study period, and 3.6% for delayed breast reconstruction. It is a safe and reproductive procedure with a single incision for breast reconstruction and nipple-sparing mastectomy. And we observe a decrease of surgery time with technique standardization and learning curve. Cosmetic and patient satisfaction appeared very good, and we propose to start a prospective study with all quality of life and cosmetic and satisfaction evaluation in our institutes. Thank you for your attention.